for many years. Dr. Tulsi sir.
Thank you, Dr. Chauhan, for those very kind words. And well, we have very distinguished Dr. Shamsher Dwivedee with us. Everybody knows him. He's probably one of the finest neurologists in the country today. And such a practical person. Anytime you ring him up, morning or evening or even at night, he will always get back to you. So, what can I say about Dr. Dwivedee? Long biodata with me here.
No need.
So, but since everyone knows him, I don't think I need to introduce him. And today he is going to talk on movement disorders, a practical approach, how to diagnose and how to treat movement disorders, followed by our orthopedic friends, Dr. Thakur, Dr. Jain and Dr. Mahapatra, probably talking on newer concepts in joint replacements. Okay, so can I request Dr. Dwivedee?
Thank you. Thank you for the kind words. Good evening, friends. Nice to meet after a long gap. Now, as you must be having the memories of yesteryears, whenever I used to speak with you, it used to be a one-to-one discussion rather than a slideshow. So, today I intend to discuss movement disorder which might be relevant to your clinical practice. Now, speaking on movement disorder without video is a challenge, but I thought I will take this challenge.
You have done it earlier. You have done it for vertigo.
We have spoken without slide many times, sir.
You have done it for vertigo.
So movement disorder, because I have to tell the audience how does a movement disorder look like. So I would act how a patient of a particular movement disorder walks and what kind of tremor you see. So that I will enact rather than a slideshow. Now, we all know that Parkinson's disease is perhaps the most talked about movement disorder, although essential tremor is the most common. Now, before I go to Parkinson's disease, because that is the mother of movement disorder, I like drinking black coffee. So just before I start, drinking excessive coffee and excessive caffeine can cause tremor, and this is essential tremor. So if you drink too much of coffee, then there can be a tremor, and patients, so when you are taking history, you must ask that how many cups of coffee you drink in a day. So coming to Parkinson's disease first, because the Parkinson's disease was described by a neurophysician named James Parkinson, and that is why the name is Parkinson's disease. And he published a series of 9 patients whom he saw at random walking on the streets of London, and he found a similarity. So he came with the initial name which he gave for this condition was paralysis agitans. Parkinson's disease was a later name introduced paying respect to James Parkinson, but otherwise it was known as paralysis agitans. Agitans means because patient was having tremor, he was agitated, and paralysis because he was not able to move properly. In movement disorder, there are 2 types of movement disorder broadly. One is the hyperkinetic type, where there is excessive movement like tremor, chorea, and hypokinetic as well. Now Parkinson's disease, why it is a very interesting disease to read is because all facets of movement disorders are seen in the same patient at different stages of life, and that is why if you study Parkinson's disease, then 70% of your understanding of movement disorder is done. You must have seen that when Vladimir Putin walks, he has a gait where one of his hand, which is the left hand, is static and the right hand moves. So there was a discussion in the Western countries because the Western people are keenly watching what Russia is doing. So they thought that he is suffering from Parkinson's. Although it was not so, it was KGB's identity. If there is a guy who is a KGB agent, the other one will understand that whether he is an agent or not by this walk. So that was a separate issue. But that is how a patient will come to your chamber when he is stepping in. Frank Parkinson's is not difficult to diagnose, but when it is stage 1, the first thing which you can see is that there is less arm swing on one side. So hypokinesia. There is less arm swing. So hypokinesia is one of the features, and that is not just reflected later on in the arm swing, it is reflected in all the activities which the person is doing. Whether he is picking up a glass of water, whether he is eating, whether he is picking up spoon, everything will become slow. And the spouse might say that, Doctor साहब ये तो बहुत slow हो गए पहले से. Or and most of the time the patient and the family would attribute it to age, because it usually starts at areas थोड़ा उम्र का तकाजा है. They will not understand it for a long time. That would remain umar ka taqaza. So there would be less arm swing on one side. And typically, later on you will find a masked face. But if you see the face of a patient with Parkinson's disease, you will see a difference between the right and the left. Initial stage 1. One side of the face would look expressionless and the other side will be more expressive. Later on, the patient would look more like this. This would be the expression later on. But initially you can see this expression in one half of the face where the person has absolutely no expressionless face, which is known as the masked faces, and even the cheek etc. would be falling down. It would be like a glum-faced person. You will think that he is depressed. Sometimes it can be misinterpreted as depression. The family would say हमेशा उदास रहते हैं. उदास नहीं रहता, उसका facial expression कम हो गया. Now the third thing is in Parkinson's disease is the tremor, which is so common, and many a time tremor, any patient, half the patients who come to me for Parkinson's diagnosis are having tremors and they are scared कि इनको तो Parkinson हो गया patient. So how to distinguish a Parkinsonian tremor from other tremors? So the Parkinsonian tremor is typically like this. It is like this. And it is also known as pill rolling tremor because basically when you are rolling the pill you do like this. So that is why this movement is the typical of Parkinson's. In Parkinson's disease you also get the postural tremor, which is when you ask the patient to stretch the hand. The fine, fast tremor is the postural tremor. Now postural tremor, in Parkinson's disease there would be both. But the resting tremor, when the patient is at rest and there is a pill rolling movement like this and at rest, so what will you say? आप relax होके खड़े हो जाइए. And then you don't make the person conscious that you are looking at the hand. You just say मैं आपको देख रहा हूँ. The moment he will become conscious and do some activity in the hand, the tremor will get suppressed. So you have to tell आप खड़े हो जाइए without telling that you are watching the tremor. And then keep watching, and after a while you will see this kind of tremor setting in. At rest. That is the sine qua non, that is the characteristic Parkinson's tremor. The action tremor that you see in Parkinson's disease may be there, but it is more or less similar to the essential tremor which just now I said. The character is more like essential tremor, but this tremor is important for a diagnosis of idiopathic Parkinson's disease, because why this is important, why this is one of the most important feature of Parkinson's disease, because there is a vast variety of diseases which can mimic Parkinson's, and they are known as Parkinson's plus syndrome, and the prognosis is usually bad, but none of them will have this rest tremor. All Parkinson's plus syndrome will have Parkinson's like there might be bradykinesia, less of arm swing, face might be mass faces, but this tremor will never be there. If this tremor is there, then you are sure that this is idiopathic Parkinson's disease. And this diagnosis is important for both treatment as well as prognostication, because most of the Parkinson's plus don't have a good prognosis. Now, the third thing which you see is how is the person watching, standing. What is this? How is the patient standing? And typically, if I am giving a lateral position, it would be like this. There would be a stoop, and the hands would be shaking like this, and this is the typical position. And then if you ask him to walk, he will have a short shuffling walk. Now short shuffling walk will only come when the disease has become bilateral. Initially you might just see the less of arm swing and nothing else. But in later stage, when it goes to stage 2, stage 3, you will find that the person's steps are short. Short means the step is short and it is shuffling like this. This is the short shuffling gait. Now, the third thing which you see, you ask the patient that do you have a feeling that you might fall? The sense of balance is impaired. Now, how to check for it? One is the patient's subjective feeling. In a late stage patient, there is hardly any doubt even watching at the walk. But if it is an early disease, then one of the ways to demonstrate is to demonstrate lack of balance is that you ask the patient to stand like this. अब मैं आपको पीछे खींचूंगा, आपको अपने को संभालना है, हाँ? गिरने नहीं देना है. See, he immediately could do it. But Parkinson's patient will move at least more than one step. If a patient has to take more than one step to balance oneself, there is a problem with balance. And this may or may not be because of Parkinson, because Parkinson has few features which are like pathognomonic, like the rest tremor. But this is not pathognomonic because this could be there in other problems also. As I said, Parkinson's plus syndrome will also show it. Then what do you see? Look for very classical about Parkinson's disease is rigidity. So what is the difference between rigidity and spasticity? That is the second question which somebody would ask then. So you have to passively pronate and supinate as well as flex and extend the hand. And what you would find is that when you are doing these passive movements with the patient at elbow joint as well as the supination and pronation movement, you would find that during the movement, patients, that you will feel a resistance, and that resistance will be throughout the range of movement. So this is rigidity. In spasticity, you might find, which is known as the clasp knife. So initially you find a stiffness and after that there is a release. So if the full range, maybe 50% you might find the stiffness and after that it would be a free movement. Whereas in Parkinson's disease, which is characterized by rigidity, you will find a stiffness which is throughout the range of movement, which is again important part of all extrapyramidal syndromes, but again it is not pathognomonic of Parkinson's disease. There are only two things which are pathognomonic of Parkinson's disease. One is this tremor, and then the next thing I will tell you just now later on.
You say resting tremor, probably more?
Resting tremor, yeah. So resting pill rolling tremor is pathognomonic, and the gait, everything which I said can happen in Parkinson's plus syndrome also. But response to levodopa, if it is more than 50% improvement in response to levodopa, that is like the investigation for, it is more important than getting an MRI or a CT done. Give a tablet of levodopa, 1 or 2 tablets in a day, and ask the patient to tell how, by what percentage are you feeling better. So for the purpose of DBS, they say the patient must feel more than 30% better. Then only the patient can be, because DBS, which is so fashionable these days, will not work in Parkinson's plus syndrome. It will only and only work in idiopathic Parkinson's disease. So this distinction is important to send a patient for a procedure which would cost almost 10 or 11 lakh rupees. So you have to be very sure that it is Parkinson's disease and nothing else. And the two tests, one is the pill rolling tremor, rest tremor, and the second is response to levodopa. These are the two tests. Now, the next thing which comes to my mind, which I will not, there are many signs and symptoms which might not be so important when you are seeing a patient in the OPD. I will not go into it. But one thing which you have to understand, that another important part of lack of balance is fascination. The family members would say, सुबह जब वॉक करने जाते हैं या घर में भी अचानक दौड़ने लगते हैं, अचानक दौड़ने लगते हैं. या अचानक क्यों दौड़ते हैं? अपने को गिरने से बचाने के लिए. So that fascination which you see, suddenly a person starts, because what he is doing is, I will tell you what is happening. So the person, if, just imagine yourself, if you are falling forward, what will you do? You will step forward. Why do you step forward? So that your center of gravity comes within this line, so that you don't fall. Now what happens in Parkinson's? So normally a person will take a step and can prevent the fall. But a Parkinson's disease patient, since it is a short shuffling gait, he can't take a large step. He will take a small step, and the center of gravity will still be out of that line, so he will keep chasing it. So he is actually chasing his own center of gravity, and that is why he is running. That is known as fascination. That is the reason why he will suddenly start running, because he is chasing his own center of gravity so that he doesn't get a fall. Because his steps are short, so he can't take one step and prevent the fall. So he will keep running to prevent the fall. So fascination, then we talk about rigidity, tremor. Now, when patients with Parkinson's disease are put on medication, the immediate response with levodopa is fabulous. But as time passes, the duration of response of levodopa becomes short. Initially, it might be again back to near normal living. There would be hardly any symptom initially, but gradually what would happen, that once the duration of the effect of medicine will start reducing, the patient will complain of freezing. चलते चलते डॉक्टर साहब बिल्कुल चलना बंद हो जाता है, फ्रीज कर जाते हैं. ये जो फ्रीज कर जाते हैं, ये this stage comes little later in Parkinson's, not initially, and that happens when the effect of medicine starts waning off. And which medicine? Levodopa. There are other drugs also. They are all dopaminergic drugs or anticholinergic drugs, but either they work on the acetylcholine pathway or dopamine pathway. I am not going into those details at the moment. The talk is focused on the approach part. So, once the effect of levodopa reduces, the patient starts complaining of freezing, number one. So, freezing can come later, and when you know that the freezing has happened, that means the patient requires more frequent levodopa dosing. So if it was 6 hours earlier, it has to be made 4 hours or 5 hours. They become hyper excitable with levodopa, and levodopa starts giving dyskinesias. And those dyskinesias are chorioathetoid movement and sometimes even dystonic movement. So what is chorioathetoid? I will come, because I said I will devote some time on what is chorea, etc. Parkinson's will remain the base. So, I am telling you what is chorea. Chorea you must have seen in your MBBS days, the typical Sydenham choreas in the wards. So, what is chorea? Chorea means a person has involuntary, sharp, irregular movements, more in the distal part of the limbs, on which the patient doesn't, and they are not stereotyped. It would be like, I am just saying how.
Quasi-purposive.
So what happens when he said quasi-purposive, what the person does, because a person feels embarrassed, so what he will do, if he gets a movement here, he will start touching his buttons. If he gets a movement here, then he will put the hand in the pocket. So as to make it look as if he is doing it purposefully for some work, so that the person doesn't feel that he is having a normal movement. So that is why it is quasi-purposive. The person will do like this. So mainly distal, irregular, no stereotypy, and usually doesn't have a torsional element, because the moment it has torsion, it is dystonia. So it will have short, brief, quick movements, and that is the first thing which happens with, that is known as levodopa induced dyskinesia, and that happens typically after 5 to 7 years. And besides the chorea, you have athetoid movement. Athetoid movements are the writhing movements. So the person will have writhing movements, and the patient will come, and what would happen, as soon as the effect of levodopa will go, the patient will become rigid and freezed, and the dyskinesia will go away. Because the dyskinesia was because of levodopa. So then it's a tricky situation where to time it in such a way that there is adequate relief as well as no dyskinesia. So we ask the patient, I typically ask the patient to maintain a Parkinson's diary. कि कितने बजे दवा ली थी, कितने बजे डिस्काइनेसिया हुआ, कितने बजे तुम्हारा रिजिडिटी हो रही है, क्या हो रहा है, उसके हिसाब से then you do the fine tuning, and that stage comes in the Parkinson's disease patient after 5 to 7 years. So levodopa induced dyskinesia and freezing, and then on-off phenomenon. What happens that the neurons in the basal ganglia, over a period of time when they are exposed to levodopa, they develop a phenomenon which is known as on-off phenomenon. Suddenly on hoga, or when it is dipping, it will suddenly become off and the person is frozen. And on also will become, he is frozen one moment and the next moment उठ करके चलने लग गया. So this on-off phenomenon starts. Now these are the findings where a person had typical rest tremor, the person has good response to levodopa. When the person develops on-off phenomenon, freezing and dyskinesia, the time to deep brain stimulation has come. Provided the person is not suffering from coexisting Alzheimer's or any dementia, there is no structural damage in the brain, and patient is not beyond, ideally one should, this is not sacrosanct, but ideally less than 70. Any person as they grow old, the positive effect of DBS will be less, and taking that risk and maybe for another 5 years of quality of life might not be a good decision. So anybody who is otherwise healthy, not suffering from dementia, less than 70 years of age, and all these findings which I just now said, this is the time when the time has come for deep brain stimulation. Otherwise, I am not going into the detail, as I said, how to do the fine tuning, because then you have to refer the patient to me. At that stage, the patient gets referred to me.
Can you finish in 5 minutes? We have other topics.
So, the last thing which I would like to tell about levodopa is that levodopa causes one problem which you should be aware. You should not attribute to some other disease. All anti-Parkinsonian drugs, they cause hallucination and mental confusion in some patients, and that is more prominent in the evening, and that is known as the sundowning syndrome. As the sun would set, their confusion would increase. So you should know that the patient is on anti-Parkinsonian medication, so it needs retweaking, dose adjustment, etc., so that it is taken care of, and some such antipsychotic which do not make Parkinson's disease worse. So that there are few anti-Parkinsonian antipsychotics like quetiapine, clozapine, which don't make the Parkinson's disease worse. So you have to choose those antipsychotics. Now why I am saying it? Sometimes what happens, they feel that the patient has developed dementia. It is not dementia. बेचारे को वो दवा से हो गया, उसको reset करना. Now Dr. Tulsi has shown me the red flag. I stop at this stage. Time बचेगा तो बाकी का movement disorder बताऊंगा.
I must say this was a class by a professor. Because all time professor.
Not only because I couldn't stop Dr. Dwivedee. I mean, such a practical talk. Never has any neurologist given such practical demonstrations of PD symptoms as he did. Absolutely, I could stop him. I wish he could go on and on and on, but probably there's always another opportunity with him. But Sean, what do you say?
Yes.
Okay. So, Dr. Dwivedee, tell us a little about DBS and stereotactic surgery. Are they reserved for patients who do not respond to drugs, or is if they respond to drugs at maximally tolerated doses, multiple drugs, but DBS is no longer an option if they don't respond to drugs? Tell us, sir.
See, DBS will work only if it is idiopathic Parkinson's disease. And for the diagnosis of idiopathic Parkinson's disease, response to levodopa is the most sensitive, so response to levodopa is essential.
Essential, friends. Very essential.
So if a patient is not responding to levodopa, it is Parkinson's plus syndrome and not idiopathic, he will not improve with DBS.
Wonderful. For some, Dr. Dwivedee, this is a life-changing modality. For others, no benefit. So, just a word on that.
So, in DBS, they say the first opening sentence in all the books is that case selection is very important. If you are, because DBS has found, how, would you like to know how DBS works? What is happening there? See, initially Parkinson's surgery was basically lesioning of the thalamus. Thalamus used to be lesioned with a stereotactic needle. And how it has started? A patient with Parkinson's disease developed a stroke, and the tremor and Parkinsonian symptoms went away. Then the neurologist thought, the neurosurgeon felt, the man who started stereotaxy for Parkinson's disease, oh, the lesion because of the stroke has cured Parkinson's disease. So incidentally the stroke happened precisely at that point where it was needed, the lesioning was needed. So that is how thalamus. So VPL nucleus of the thalamus, they started lesioning. But the problem with lesioning was that it used to sometime cause hemiplegia, and if it was a dominant cerebral hemisphere, then even aphasia used to happen. So then they said that we will not damage the tissue. So what it does, so DBS is basically a stimulator. So when you go to your first year guide, stop functioning. So DBS, what it does, the tip of the needle stimulates a micromillimeter zone of neurons in that area to a persistent depolarization state, which has an effect of lesioning because those neurons have stopped functioning. So for different diseases, now DBS is being used for essential tremor, now it is being used for epilepsy, now it is being used for pain syndromes. So for each condition there is a location which is to be, if you are precise in your surgery, and more than that, if you are precise in your case selection, then only DBS is helpful, otherwise it will do more harm than good. In case of Parkinson's disease, as I said, if the patient is already developing dementia, the patient already has a brain, if an MRI, do an MRI, if there are brain lesion because of multiple strokes, he is not a fit case. Suppose somebody has Parkinson's disease and also multi-infarct state because of uncontrolled diabetes and hypertension, he is not a fit case for DBS. So there should not be structurally too much of injury to the brain, there should not be dementia. The patient should be otherwise physically fit. That suppose if a patient is having, as my orthopedic friends were saying, is because of osteoarthritis, is already wheelchair bound. What is the rule of doing DBS in such a patient? It will not be. So you have to see that whether it will finally help the patient or not. That clinical assessment has to be done. Besides neurological, the general health condition has to be fine, and preferably the age should be less than 70. Deep brain stimulation.
So let's proceed to my last question, Dr. Dwivedee. The role of pramipexole, is it better as an anti-tremor, better anti-tremor effect as compared to other direct dopamine agonists?
So as far as these are known as the D2 agonists, and besides levodopa, this is another group of drugs which are helpful in stimulating the dopaminergic D2 receptors, and that helps in alleviating the symptoms of Parkinson's disease. Out of the drugs besides levodopa, see, levodopa is not the best drug for tremors. Levodopa is not the best drug for tremor. Levodopa is best for all other symptoms except tremor. It does reduce tremor, but the drug which is considered the gold standard is trihexyphenidyl, which is Pacitane, which we use. That is the gold standard for reducing tremor, but it causes anticholinergic side effect, dryness of mouth, prostate, those who have benign prostatic hypertrophy, it can cause urinary retention, it can cause glaucoma, all these can happen because of its anticholinergic effect. So in elderly, in the age group where Parkinson's happens, it is slightly tedious sometimes to balance the side effect with the positive effect. The drug which is very good and which is overall a very good drug, which is less used, but it has a good impact on both tremor and other Parkinsonian features, is amantadine. So if one uses pacitine, amantadine, and as I said that there is a slow tremor, a fast tremor also beside the pill rolling tremor, there beta blocker will work, propranolol. Not all beta blocker, propranolol. So propranolol, pacitine, amantadine, these are the mainstay of tremor treatment. Where tremor is not responding, increasing the dose of levodopa will not help. You have to take help of these drugs to control the tremor. Now this debate, which is more out of the other drugs like ropinirole, pramipexole, levodopa, which is better? Pramipexole has slightly better effect on two things. One is tremor and the other is also an antidepressant. It elevates the mood. So it is a mood elevator as well as positive, but where tremor is a problem, these three drugs, trihexyphenidyl, amantadine and propranolol will help me more, and sometime a low dose of clonazepam. Clonazepam also reduces tremor.
So,
He wants to ask some question.
let me complete, sir. So, probably next time we'd like Dr. Dwivedee to talk on essential tremors and restless leg syndrome, which is so common. Give us the date, sir, for that. And Dr.
Sir, wonderful talk. Can I have a mic,
Please.
I would request all of you to keep calm for next 10 minutes. Some questions which you might have in your mind regarding Parkinson's, all of you see tremors in your daily practice. Do not hesitate to ask questions.
Even if I have not given a talk on essential tremor, if you ask a question, then one can answer.
Wonderful talk, sir. Let me congratulate you for a wonderfully demonstrated talk. One of the common sense talks, as I said in the introduction. Sir, you said about DBS. What is the cutoff age for DBS?
So, sir, as I said that there is no sacrosanct cutoff age, but below 70 the outcomes are better. Beyond 70 the outcome is not so good.
Sir, you also mentioned about a drug called amantadine that we learned when we were doing our MBBS, actually in appearing for final year in 1983. The drug is not much used. Any reason for that? I mean, I am a physician practicing as a consultant physician, but I have hardly ever used amantadine, not because of my ignorance, but simply because by the practice of usage, we don't see too much people using amantadine in practice.
So that is why I highlighted amantadine, because it is a wonderful drug in a situation where you have to treat mild to moderate Parkinson's, and particularly when because of levodopa induced dyskinesia which starts after 5 to 7 years, you have to reduce levodopa and get rid of levodopa, then these are your saviors, drugs like amantadine, because they work both on tremor. The only thing which you have to look for is it can cause something which is known as livedo reticularis, where there is lines appear on the shin and the legs, and it can cause fluid retention in the leg. But it is not common, it is very rare. Amantadine was introduced as an anti-influenza drug. That was the introduction. And when a Parkinson's disease patient with influenza took it, and then lo and behold, he said it's a wonderful drug, it also cures my Parkinson's, and that is how. So it was not proved in its original trial. It was a post-marketing finding that amantadine is useful in Parkinson's disease, and in my practice I use it in early Parkinson's where tremor as well as rigidity is there, and I don't want to start levodopa too soon, then I would use amantadine. And when levodopa induced dyskinesia is troubling the patient too much and I have to reduce levodopa and still give him anti-Parkinsonian relief, then it comes to rescue.
Sir, we also see
Amantadine probably is for dyskinesia and has a lot of side effects like.
Which one?
Amantadine. For dyskinesia.
No, it is not a treatment for dyskinesia. It is a treatment primarily for tremor and all anti-Parkinsonian. But when a person gets levodopa-induced dyskinesia, see, all anti-Parkinsonian drugs can cause dyskinesia. All. I am talking about a condition where the patient is not able to tolerate levodopa after 5 to 7 years, when levodopa-induced dyskinesia has set in. The only way you can give relief to the patient is by reducing the dose of levodopa. But what you have to lose in bargain is the gait, rigidity, everything will set in. But the moment that is the time when ammental becomes, steps in and helps you.
Sir, is one of the causes why amantadine is not so much in vogue in the hyper elderly population is because of the pro-arrhythmic action of amantadine?
So again, the pro-arrhythmic action of amantadine is not limited to amantadine, even levodopa causes arrhythmia. So it is the question of how you dose it. So suppose if I have to start amantadine now, fortunately it is available as a score tablet, 100 milligram score tablet, I will start with 50 and then proceed. Otherwise even levodopa causes cardiac arrhythmia. All dopaminergic drugs they can cause cardiac arrhythmia, even pramipexole, roperidol, all of them cause cardiac arrhythmia. So that is basically how you escalate it, how you dose it, and on every visit, do you check the pulse? If you check the pulse on every visit on a patient who is on anti-Parkinsonian drug, you can avoid that scenario.
There are some new kids on the block now, sir. We hear about anticapone, syncapone. What is their role?
So they prolong the half-life of the drug, levodopa. So what happens is that they are the voltage stabilizer of levodopa. Why voltage stabilizer? You give a tablet of levodopa, there is a sudden rise and then sudden fall, sudden rise, sudden fall. By giving syncapone, you are smoothing it out. So your voltage fluctuation will come on the profile, drug profile, you will find that the voltage, the drug level is better. It has smoothened out. The sinusoidal wave becomes like a plateau, and that is why it helps in a better control of that.
Sir, my last question. We usually think and visualize Parkinson's to be a disease of the middle age or the elderly. I am sure that is not true, and you must be having very young patients with Parkinson's in your practice. What is the youngest patient you are treating for Parkinson's?
The youngest patient that I have treated for Parkinson's is around 24 years old. And most of them, the Parkinson's in young, the Parkinson's and elderly Parkinson's, they are different on a genetic on a genetic platform. They are different. The young Parkinson's in genetically is different from the Parkinson's which happens in 60s. That difference is known, but it has not got any therapeutic implication as yet. So maybe in future, whether it is the Parkin protein or whether it is synuclein which is responsible for the disease. So basically Parkinson's disease, Alzheimer's, all these neurodegenerative disorders, they happen because of deposition of abnormal protein around the neurons which sequesters the neurons and kills them. उसका गला दबा के घोट देते हैं न्यूरॉन का. Now these different types of Parkinson's have different genetic background and the different type of proteins are being. So tomorrow if there is a protein specific treatment, then this will become important कि इसको किस variety का दवा दिया जाए, whether anti-Parkin or anti-synuclein to delay the progression of the disease.
Sir, my very last question, is there any role of coenzyme Q10 in Parkinsonian degeneration?
Yes. So coenzyme Q has a level B evidence in the dose of, it was tried in 600, 800 and 1200 milligram dosage per day. In the dose of 1200 milligram per day, it was shown to slow down the disease process. It has a level B evidence. Very expensive drug if you buy it from chemist shop. It is cheaper if you buy it from Amazon India, and it is even cheaper if you buy it from Amazon US, and you don't need prescription.
Over to you, sir.
What a wonderful talk, sir. I don't have any words to explain my gratitude to you. I was so mesmerized. I am impressed by your earlier talk without slide on vertigo. It is still going in my brain.
Can we hear it for Dr. Dwivedee?
Sir, micrographia was also supposed to be one of the earliest symptoms of impending Parkinsonism. Do you agree? Because when I saw my handwriting going very small, maybe I was saving the paper, so I was thinking in my mind, I am going towards PD. What's your comment?
Now, micrographia, yes, it is one of the features of Parkinsonism. So it includes all the Parkinson's plus syndrome as well. It is not specific for idiopathic. Why my talk was more focused towards how to distinguish between idiopathic.
But we have to draw many other things, sir, other than your talk. Sir.
So So Parkinson's plus syndrome as well as idiopathic Parkinson's disease will cause micrographia. As far as coming to micrographia in elderly, let me tell you, with passage of time, beyond the age of 80, in each decade, beyond the age of 70, not 80, beyond the age of 70, in each decade, you will find around 20% elderly developing Parkinsonian symptom, because the neurons of substantia nigra are bound to degenerate with time. So some degree of Parkinsonism starts setting in after the age. That is not idiopathic Parkinson's disease, because the neurons are not critically low in number to cause a frank Parkinson's disease, but since they have reduced in number, so you will find elderly also have a stoop, they walk with short steps, may not be shuffling but short steps, and their handwriting also starts changing.
So what I am asking are my pre-questions. This was pre-question number 1. Pre-question number 2 is, we have a vaccination in pipeline for Alzheimer's, which is a degenerative process. Again, PD is a degenerative process. Do we think we can have vaccination for PD also in future?
So yes, one of the strategies which is recently Alzheimer's, they have come with a monoclonal antibody against the amyloid.
Tau proteins.
Amyloid.
Tau proteins and amyloid.
Amyloid. So amyloid, anti-amyloid monoclonal antibody is a reality today. There is a debate whether FDA was very fast in giving the approval or not, because there is a lot of controversy going on, and companies, the insurance companies saying that we will not pay for it because it is not adequately backed by science. You have been in a hurry to give the approval. That is a separate issue. But this strategy of monoclonal antibody against these bad proteins, whether it is the Parkin protein, whether it is the synuclein, whether it is tau, or whether it is this, has opened a door, and you will see immunotherapy. Let me put it immunotherapy, both monoclonal antibody as well as vaccine both. It might be a reality, because after this opening of adrenal lab for this Alzheimer's disease. So this has opened a pathway, and I think it will become a reality.
My last pre-question, my questions are not started, sir. My last pre-question is, as you said, it was initially named as paralysis agitans. So should it not be paresis agitans instead? Paralysis means paralysis. Paralysis means weakness. Paralysis means without movement.
Yeah, but
Sir,
it is more.
just give a thought.
It is that term is no more used in textbook. It is a more of a historical.
So do we have any hemi-Parkinsonism?
So in
Hemi-Parkinsonism, as we have in Putin.
I said initially that when it is the early stage, one side is usually affected, not bilateral to begin with.
Just to finish my last question, I was reminded of Kesto Mukherjee, that when he had his drink, he was normal. So as you said that levodopa, when it starts gaining its effect, you have to take extra dose. So is it tachyphylaxis in any form?
Tachyphylaxis and this phenomenon has a different pathophysiology. What happens is, it both tachyphylaxis and this phenomenon, levodopa, long-term levodopa associated change in the drug metabolism locally in the neurons. This change is not, I won't say it is tachyphylaxis, because in tachyphylaxis, if you keep increasing the dose, the patient will become better. Here the problem is that if you increase the dose, the dyskinesia would increase. So the neurons have become, the sensitivity of neurons involved in extrapyramidal circuitry, their response to levodopa has become erratic.
Sir, my last question to the knee replacement team.
No. Next time we are going to ask him.
Sir, just last question.
Next time we are asking.
Knee and gold knee, just last question, sir. Gold knee. Do you test for sensitivity to gold? Because some people are having sensitivity to gold also. कहते हैं बात सोने को जा रही है जहाँ से फूटे कान, तो क्या उसकी सोने की सेंसिटिविटी चेक करते हैं?
Next time with them.
Sir, gold is a misnomer. It is not gold.
Next time उनके साथ में.
See the time.
Sir, it is not made of gold. It is just a coating.
आपका दोस्त है.
It is just a coating which is color golden.
Dr. Dwivedee.
It is not a gold covering. It is just a color which is golden in color. It is basically titanium niobium alloy. It's a niobium titanium alloy which is covered over the implant. It is not gold. It's just a gold. It's just a gold color.
Plated भी नहीं.
It's not a gold plated implant. It's not gold. It's just a niobium implant.
We are having next time with them.
Dr. Dwivedee, thanks, sir. You are a master. And thanks, sir. बहुत अच्छा लगता है जब आपको सुनते हैं. और सबसे इम्पोर्टेंट, विदाउट स्लाइड्स आप इतना समझाते हैं तो हमको स्कूल की याद आती है कि जो हमारे टीचर होते थे, ब्लैक बोर्ड होता नहीं था तो हमको ऐसे पढ़ाते थे. सर थैंक्स, गॉड ब्लेस यू. माय क्वेश्चन इज सर, आई एम अ सेक्सोलॉजिस्ट. आई ट्रीट सेक्सुअल मेडिसिन. हम बहुत सारी दवाएं यूज करते हैं. आई यूज डिपॉक्सिन, पेरोक्सिन, आई यूज सेरोटोनिन. आपने मेरे को बीच में बताया कि देयर इज सम ड्रग व्हिच इज मूड एलिवेटेड. डोपा के बारे में आपने बताया कि इट्स अ मूड एलिवेटेड. So my question is, sir, we use digoxin. It's a master drug. It is doing very well in erectile dysfunction, premature ejaculation. बहुत बढ़िया काम करता है.
Which one?
Digoxin, peroxetine हम यूज करते हैं, सेरेटिलिन यूज करते हैं. तो सर आप अभी कह रहे थे कि मिथाइल डोपा. सर प्लीज.
See, अब आपको मैं एक राज की बात बताता हूँ जो आपको प्रैक्टिस में हेल्प करेगा. जब पार्किंसंस डिजीज का पेशेंट आपको कहे कि मेरी सेक्सुअल लाइफ डिस्टर्ब है, तो आजकल एपोमॉर्फिन टैबलेट आ गई है. एपोमॉर्फिन टैबलेट हाफ एन आवर बिफोर गोइंग टू बेड, सबलिंगुअली, that will do the trick for you.